You guys, you have Abby, you have one of these, like, so, and you guys are sharing.
Yeah,
You
we're
may as well-
sharing. Yeah.
No, you don't have to share because nobody else is here.
Okay.
Oh, good. I want my own.
I don't blame you. I should have given you this time. So, this is Shannon. It was so nice to get this up so we could see what was going on. Looks like we've got quite a bit of money.
Mhm.
Expenditures, the T-shirts of which you're still handing out, which I think
Yeah.
that gives us a presence.
Mhm.
They handed out T-shirts at the fair, plus the some of the T-shirts.
Where'd you guys at the fair?
Across from the Republican booth.
Who was in there when I walked?
There by Mike Carr, Bethany LaRose.
Mike was in there, yes, yes. And he came over and talked.
Is Bethany the
No, I didn't try.
lady at the hospital?
Yes.
Yeah,
and
she's not there
Do you know
anymore.
she's leaving to go to the high school?
To do what?
She's doing like community outreach. Yeah, so she'll be very key in incorporating things, 'cause she's still staying on all the same committees. So that'll be
Yeah.
nice.
Sorry, I'm looking for the keys to the car that I drove and I can't find them right now.
Are you leaving right now?
No, but I don't know what I did with them.
Are they, yeah, well,
Right there they are. I'm good now.
I was gonna ask if he's related to my wife.
Well, we have keys to get in the building. We have keys for the vehicle. We have keys to do the disc thing. So we got a lot of keys in the health department. So I couldn't find them. I'm good now. I'm okay. I'm
Nice.
not.
We went into church last night or something. There was a pair of keys like that laying on the table from Toyota. Somebody left them in church on Sunday.
Oh,
How'd
We
they get
figured the
home?
wife must have had the other set. in
another
her
fob or
purse.
something. Oh
Oh,
my
no.
gosh.
either that or the guy left them. It's still even.
Yeah.
I've,
Oh, I didn't say anything about who left them. I said the wife probably had a pair in her purse.
Oh,
so that means the guy left them.
yeah, car started. Yeah.
Uh-huh.
Hey, Kamar, can you hear us?
Yes, I can hear you all.
Okay, great. Do you want to do you want us to do introductions for you? Because we have a couple people here you might not know.
Yeah, sure. That would be great.
Okay, so you know me and Deb from the
Hi,
health department.
Tamara. Good to see you.
Come on, my name is Susie Drish. Welcome. Your turn.
Hi, Kamara. I'm the tail twister of this group.
So
Joe Ledger.
All right.
they're both supervisors and
Okay.
I'm Abby. I'm from the auditor's office.
All right. All right. And then I'm Kamara. I'm a prevention specialist at Community and Family Resources. So I'm in the Iowa City location, but I have the tobacco grant administered by the IHHS, which is now Iowa Primary Care Association, basically. And so I do a lot of tobacco work in the county. So I am the go-to on all things tobacco, nicotine. Do presentations. I have lots of materials to give out. And since I do also work with opioids just in other counties, I can offer whatever advice or input that you'd like.
Nice.
yeah.
Thank you.
And Kamara attends our Alcohol and Tobacco Free Coalition Zoom. So yeah, so she's not 99% of the time you're on that Zoom, I think, almost
Yeah.
100% of the time. So she joins us. But
Nice.
we're taking a break for the summer months. Historically, we don't meet during the summer because our school partners are not available, obviously. So we're going to meet again September 8th. So, yeah. Anyway, and Kamara.
And
attends.
that made me think that's probably why we don't have so much attendance this summer because they're off on break.
Well, a lot of people are, and I don't think people know, I don't think people, it's not a routine meeting. I mean, it is, but it isn't. So I think if they don't get a reminder, they just space it off. Like, like I forgot we had a Zoom today at 11 o'clock. Deb's like, are you doing that Zoom? Oh, I didn't even register. I don't even know if I got the email. So I think it's just a communication thing, but
Hey, anyway, back to expenditures. Looks like the T-shirts are going well. Tall Cop, have we got all those
I
invoices in
think we
to
got.
give to Darcy?
I think we got everything. I
Okay.
think we paid him, we paid the room. We should have gotten an invoice for the CEUs to be processed from Indian Hills. I think, unless Connie has something outstanding, Mayor Boyer, I think that that's everything.
Mhm.
So I don't know. I didn't total everything up. Maybe Darcy could do that
Yeah. So,
for us, but
I know there that they've at least got up to 20,000. So
yeah,
it's
yeah.
gonna
So
go
there's
down.
still some money.
We
left
talked
for
last time about if you guys want to do talk up again, maybe we should get on that.
Yeah. I think we should probably see what that looks like.
That way we can give the supervisors a date and we can vote on it, you know?
Yeah.
Because that seemed to go well, except for maybe the evening part.
The evening class did not go well, and I think, I'm just gonna be honest, I think a lot of times the people that really need to hear the message aren't the ones that are hearing the message. There's a lot of other things going on that evening. I mean, there's always stuff going on. When you have kids in school, you cannot pick a day and a time where everybody can be there. I think it would be more beneficial, and maybe we could get this information from Bethany since she's switching roles,
Oh,
to be like, have it be during a teacher work session or something. I think
Yes.
that would be a more focused approach for that education. I think we get better bang for the buck, so to speak.
so that means you'd have to coordinate with Bethany when
Yeah.
usually
Yeah.
it's on a Wednesday, isn't it?
Yeah, I think so. So I think until she gets in her new role, I think, that's what I think. I think
Yeah.
I think our school district needs to hear him.
What about the other school districts?
Well, I mean, yeah,
Yeah.
I mean, they were all invited
Yeah.
to, I mean, everybody got invited to the
Okay.
day session.
Yeah,
And
But it's just hard when everybody's at
No.
school.
sure.
Van Buren.
Yeah, and even if we had it during the summer, I
Mhm.
don't know that we'd get good attendance, to be
Mhm.
honest, because everybody's like, it's
No, I
it's my
get
day
that.
off.
Right.
You know,
Yeah, but that's just what I'm thinking.
Right.
I don't know. Kamara, have you ever heard him? I can't. Yes,
Talk Hub?
yes.
I have not, but I've seen the advertisements and people say good things about it though.
Yeah,
Mhm.
he has a newsletter that you can sign up for from Talk to Stop. Yeah, that might be something, because it's all about the new latest drug trends. I know we talked about it during the ACT meeting,
Yeah.
but anyway, I don't know.
Mhm.
And I have not reached out to him to get him on the schedule. I don't think Connie has. I haven't talked to
No.
Connie, so.
But he said he's gonna be circling around.
Yeah,
in
he tries
this
to coordinate
area.
he tries to do
Right.
all these stops in Iowa or all the stops
Yeah.
in
Right.
whatever state he's in.
Mhm.
Makes sense.
So, yeah, it'd be
Yeah.
more cost efficient with his scheduling and
Oh, yeah.
stuff, so he doesn't have to double back.
Mhm.
I mean, I could send him an email and see what he's got, like the fall of 26. Which is just a few months away when you think about it. I mean, it's like 15, 16 months away.
Yeah.
Yeah.
I mean, not
Yeah,
quite.
How long did it take to get him here this time? How many months?
It was
did you
about
work?
a
Almost a
Good
year.
question.
Yeah.
He said when he was here in April and his schedule was already filling up for the next year, it'd be after
Yeah.
April. So I'm
That's why I
thinking
was
like,
thinking maybe we should just get a date.
I'll email
Yeah.
him and see.
And you might ask Darcy if we've gotten all those bills in from him.
I'm pretty sure we have. I mean, I'll ask her.
And if you have it, it's your fault. Make sure you tell him that.
And you got the
You
muffins.
don't have an idea how many dollars was spent yet.
No.
No, it was well under that
Yeah.
amount though.
Yeah, I figured it was, but I was disappointed at the one over here. There wasn't more people there.
Mhm.
All the money we spent on that.
Over here at the convention center?
Yeah.
Oh, really?
There
Oh,
wasn't that many people there, I didn't think.
Oh, we
I
were
thought it was a
full
good
for the
turnout. I thought it was a good.
Oh, I was
turnout.
thinking something else, I'm sorry.
Yeah, I'm like,
Yes.
oh gosh, yeah, the room was, I thought there
Yeah.
was 50 people there. I thought that
That's
was a
right.
pretty good turnout. The
Uh-huh.
evening class wasn't very good. I mean, there was less than 20 people there, 15,
Yeah.
less than 10 probably. By the time you take all the, like
Yeah.
Connie and I out of the equation. Pat McAvan came, which was good since he's a
Mhm.
juvenile judge and that was
Yeah.
good.
Yeah, that's really good.
So, yeah, but I mean, I think we had about what they had in Keosauqua a year ago.
Oh, yeah.
Mm-hmm.
Exactly.
Yeah, yeah.
Mhm.
They had in Keosauqua?
Mhm, that's where we
Uh-huh.
heard him
Yeah.
originally.
Oh, so you'd heard him before?
Yeah.
Okay.
I thought he was great. Okay, so I'll follow up on the invoices too. I think we've got them all, but I'll double check.
They just had a newsletter and they said that what's really, really increasing is vaping.
Oh, yeah.
Because it used to be you'd buy a cartridge and it was like 15,000 puffs. Now you'd get the same price or even lower and you get 50,000.
Ah,
So kids are.
And it's not regulated
I
like
see we're gonna
tobacco.
have a new vape shop in town,
Where's
Where
that at?
the old video building. They
That's
now-
a vape shop?
It's now listed as liquor, tobacco and vape. They've got a
Oh.
banner
Is that
put
in
up
that
there.
strip mall?
No, the old video at the corner of 9th Street. and Burlington.
That's
Yeah.
big.
Huge.
The
Family
building's set
video.
empty forever where the.
Is that what that's doing? I know Liberty Communications is building.
They're
a big
taking
building.
half
Yeah.
of it and this vape shop's taking the other half.
That's why they built the south door then to go in.
I have no clue what it is that
Oh,
about that.
man.
The
Wow.
banner just, I heard about it a month ago and the banner just went up. I noticed it
Wow,
yesterday.
because that's a big space.
Yes.
It's a huge space and they,
Cause you looked at that for.
We did
you
look
guys.
at it.
1,000 a month or something
It was
crazy.
unbelievable. Well, and the owner,
9,000
it was the
something.
family, what was the video? What was the name of the video? Was it Family Video?
Yeah.
Mhm.
Their corporation did not want to sell the building. They only wanted to rent it. So I don't know if they've changed their tune and now they sold it. I can't answer that, but it was thousands of, I mean, it was a huge amount of money.
Yeah,
Maybe
monthly
Liberty is
ridiculous.
just gonna rent it. They're taking the north half for business offices.
I don't know.
Yeah, well, there used to be a house where they built that.
Yeah,
And
Yeah,
I just don't know how they're gonna be able to go in and out to that little alley and then,
they got a door on the south side.
oh yeah, they got lots of doors.
Hmm, just
Their
what we
equipment's
don't,
pretty big.
I
we don't know. Yeah,
Needs,
yeah, it's tough. Yeah.
Okay, what else? Booklet, she said Bethany,
Yeah, that's on hold because Bethany, I don't know who I need to reach out to. If it's marketing, I'll follow up on that too. We'll follow up on that. Once they get the booklet updated, they were doing a format, they were doing an annual update and a formatting update to make it more cost effective when they print. I'll follow up. I'll email Amy. Amy
because
Becker.
boy, it'd be sure nice to have that at least before school starts.
Yeah.
mhm.
Booklet, and I'll CC you, Deb.
Okay.
If I don't get it today, I'll do it tomorrow, but, okay. And then once we know, Susie, I'll let you know.
Yeah,
I mean, I
yeah,
hate being CC'd on emails when I don't have
yeah.
anything, you know.
Elizabeth would have been here today, but she has a trial,
Oh,
so,
I figured something was
Wonder,
going on.
there's
There's a lot of
like
cars.
oh dear, on the
Yeah.
roads.
Uh-huh. Mhm.
It's still under family video.
Is it?
Yeah.
Yeah. So the Strengthening Families Program, the ISU is, that's been committed, and I believe the extra folks that are gonna get trained are going to go to Ames in August to do the training. And they're gonna start in October with the kids.
Oh,
Jay
nice.
Thompson and a couple other teachers from the high school.
Bethany's actually going to that, I believe.
Oh, really?
Mhm.
Oh, really?
She's going to one in July.
Uh-huh.
I wonder if that's. thought it was
Yeah, I'm
this
just anxious to
building.
see how this works. You know, we're taking a lot of leaps here.
Mhm.
What else here? Road to recovery shelving at the library, $3,000. And Abby has said that Alex McCunis from the library has wanted on the agenda, but he's not shown up for. I saw he was on the agenda yesterday. I don't know about the prior, but he hasn't shown up.
Mhm.
So the mayor made a request on his behalf, correct?
He
Initially.
reached out to Connie.
Yeah.
Connie got a hold of me,
Yeah,
and we've already given. We voted instead of 1,000 to give him 3,000.
okay.
Now it sounds like he might want a little more. I don't know because I haven't talked to him. Abby, did you get a hold of him and see if he wants on the agenda again?
I don't.
Okay.
Well, I know at one time Ken was gonna be requesting
Yeah.
funding for something to do at the library, and I guess I thought that,
It was the.
I thought it was the same thing.
It
I
was
thought it
like
was too.
the billboard thing, or where you could the advertising.
I think
Yeah.
the reason we went ahead and gave him 3,000 because the billboard and then the movable cart to go places.
Yes.
Yeah, yeah.
Mhm.
So I don't know what's going on there.
Mm.
But I think they've already got their money.
Mhm.
In the detox services, this lady that works in this county, and I cannot remember her name, said that they had to help one person last year, and this is what it cost us. She'd like money to do it once more. So we voted for that in a meeting to let her do that. I thought she would be covered. She said.
Was Cedar, you remember, Susie? Or was it, I'm just trying to figure out who it is for.
Name doesn't ring a bell.
No,
I don't think it was from
Okay.
CETA, but CETA has lots of arms.
Yeah, no, I know they do a lot of that training.
So I don't know, I guess I would like to see us talk about what else we could do.
Didn't we have a conversation at one time with Elizabeth? And it's hard because she's not here, so. Didn't we talk about drug court or some kind of transitional program with the inmates that were incarcerated? I'd really like to see us do something with that demographics. So when they leave jail, they have the support in place
And
to maybe
resources.
not go back to jail. You
Right.
know,
We used to do something like that. The first experience I was in Cedar Rapids, and we did one down here where we invited all these folks with records, were employed, people that were in jail, like as a jail diversion thing, get them in there. And
Mhm.
what we did was have around the outside of the room was employers that would talk to them. Similar like a job fair just for offenders.
yeah, yeah,
That's great.
yeah.
Yeah,
They
it-
need that,
it-
they need something. when
It
they
really
can.
was good. Cedar Rapids did it way better than we did.
Uh-huh.
But
Well, and the thing of it is too, it's not, I mean, even if somebody doesn't want to make an appointment with a counselor or therapist, or if they're not ready to go to treatment, you
Right.
can't make anybody do that. They have to be in the correct frame of mind and be willing to do that work. They're the ones that have to go through that. We can't fix that for them.
mhm,
But even if you're getting out of jail and you don't even know what resources you have in this community, like food, or if you're a veteran, or if, you need to go have some dental work done and you don't have any insurance, and where can you go to get X, Y, and Z services in the community? I just think it would be nice to work with Sherry somehow, since she's a jail administrator, and see
oh, yeah.
what that would look like. Kamar, do you know, do they have any, are you involved in anything like that?
No, so I really just do prevention. So not really anything with clients or on the behavioral health side. Like
Okay.
the most I do is like I teach the OWI class, but
Oh, okay.
Oh,
that's really it.
Okay. When CETA does our OWI class,
Uh-huh.
they do that driving class. So,
I used to do that driving class for Indian Hills.
nice. I don't know. I just think it would be nice to have a conversation to, like, Sherry and I've had this conversation before, because I know we met with, oh my gosh, I think it's Molly from River Hills, and about some testing that she can do at no charge. And so then how you can try to bring all these community partners together to try to offer one service for one entity.
Yeah.
I think it would be a good thing
Right.
to try to, because you're just going to go back to where the same environment, and you're still going to have the same social
Same
determinants of
people.
health, the same needs, whether it's
Same
food,
friends.
shelter, clothing, access to healthcare. You're going to have those same issues,
Mhm.
whether you've been in jail 30 days, 60 days, 90 days,
Yeah.
or 4 days. I mean, you don't know where you can go to get some assistance to try to get on the right track. I don't know. Anyway. And having worked in our jail, I see
So
that as a.
The booklet will be good then, the resource.
Yeah. Yeah,
Yeah.
it will be.
Because we talked about doing them specifically for people in jail,
Mhm.
like resources they
Mhm.
would need, rather than the whole
Yeah,
booklet that includes everything.
yeah. But then we're just like, I think it's easier just to give them a whole booklet and it's all tabbed out, instead of doing some separate. 'Cause
Right,
it's,
right.
Mhm.
because you never know, they could give it to somebody else and say, hey, we need help with this or whatever, so. I think there's a lot of services in town and in our community that people don't realize we have, is what I'm saying.
Yeah, I don't even think we know.
No, I don't think you guys, I
Yeah.
mean, I know a lot of services that are going on in the community. I mean, our department does, because we get phone calls, or we're involved in
Same.
meetings, or we're talking to people.
Mhm.
But I don't think the general public knows all the services that are available,
Yeah.
is my point. So,
Yesterday in our supervisors meeting, Andy Holman showed up for 15 minutes.
oh wow, I haven't seen Andy for a long
He
time.
looks great.
He's our newspaper guy. He's our news.
Yeah.
Okay.
But I just thought it's too bad he couldn't do an article about the opiate group.
Yeah.
But
Mhm.
And that's
then
what
who reads the newspaper?
I know.
we don't,
Maybe it's on Facebook.
I don't know. I'm hardly on Facebook. I
Yeah.
can't take it anymore. I have a very limited amount of tolerance for social media. So that's just me.
Yeah.
Hmm.
I have to do it to protect my own mental health. Seriously.
Any other ideas what we could do? I know Ken's in Canada for a while, right?
Oh, he
Yes.
probably went back home,
Yeah,
home,
yeah.
quote home, since he's from Canada. I think he thinks that we're home
He's
now.
back for 2 months.
Yeah,
Mhm.
so,
Well, good for him.
Yeah,
yeah. I think it would be so cool. I mean, years ago, there was the DARE program.
Yeah,
You know, it'd be fun if they could do something like that, but you know, I can't speak to anybody in law enforcement's responsibility. I know everybody's short-staffed and everybody's
Yeah.
doing more with less, but I think that kids in grade school need some
yeah.
information presented to them. Preschool, actually. I mean, I've said this for years,
Mhm.
because kids are exposed to all sorts of bad things in their home environments and
oh, yeah.
other environments. And
Yeah.
They're little sponges.
they are.
Yeah.
I mean, my kid is 6 and he's taught about healthy food, so he'll come home, is this healthy? Is this healthy? At 6, so
Mhm.
Yeah. It makes more of an impact,
he
I
wants
think.
healthy ice cream.
Don't we all? Is that called sugar? Is that
I
called
know.
invisible ice cream? I don't know.
It's called custard.
Oh, yeah.
Give him the ice.
Yeah, you have a slushy that's full of sugar, you know, Kona ice stuff.
You know, I think nothing's immune to that because my niece goes to a Christian school. She's already saying bad words.
Oh, yeah.
That's where you learn them.
I know, a
the
Christian
bus.
school.
The school bus is where you learn all
School
this
bus.
stuff.
Yeah.
Yeah, I don't know.
But I always have thought that the younger they are, the better to.
Yeah.
It's
Can't
true.
shut up.
Yes.
It's true. Just have a baseline conversation and just, because they're already exposed to stuff. They're already in situations that are not
Mhm.
very conducive to appropriate development, so. I will share this, I did share this on Facebook the other day on our work Facebook. I'm gonna get on Facebook right now, and I just dissed it, because I can't remember. It is about human trafficking. And let me find it here just a second. Let me get logged into the right. Why is it when you want to get logged into your other
I
account?
know. They had a program in Keosauqua.
No, that's coming up. That's what I shared.
Oh, at Hotel Manning?
Yeah, that's what I shared. It's
Oh,
coming up
right.
in July.
Okay.
Yeah.
I thought it already was.
No, that's what I'm gonna share here just a second. I can't find myself. Public health. So. It is. I don't know if you've heard of it. It's called Grid Shock, and the goal is to have this presentation or film presented in all 99 counties across Iowa.
Grid shop.
Grid Shock. It is Friday, July 25th at 6:30 at the Hotel Manning. And it's about human trafficking, human sex trafficking. Are you already on a Facebook page?
Mhm.
Yeah. And one of my friends that lives in Van Buren County shared this with me months ago and asked me to share it.
Oh, wow.
And then it was a timing issue, so I don't want to share it too soon. So yeah, so I would encourage anybody to go because I attended a session on human trafficking a year ago at an emergency preparedness conference in the Quad Cities. So there was law enforcement from the Iowa side of things and the Illinois side of things, local, state, and federal people involved in this presentation on human trafficking. And it is real, and it happens across all social norms. I mean, people think that, oh, well, they're not really getting trafficked, and they are. So
Is
it's.
the truck stop one of the biggest spots?
Oh,
Yeah,
yeah.
it's very eye-opening to sit and listen to people being trafficked and how they cannot get out of it. I mean, it's just unbelievable. So anyway, I just wanted to bring that up, and like I said, I should
Mhm.
share
So how
it.
can we relate that back to opioid? I
I think
like
it's
this.
all encompassing. I think sometimes it's like which came first, the chicken or the egg? Did
No,
your
I agree. with you.
trauma come first as a child, your ACEs scores, which are your childhood childhood trauma scores?
Mhm.
Or was it, somehow abused? Did you use drugs? Did you have an undiagnosed mental health issue? I think it's all encompassing. And I think you are vulnerable and you are not able to, you don't even realize you're being groomed and trafficked.
So like, it's almost like a
It is.
to the
It is.
opioid. I just
It's-
want to be able to tie it back.
Well,
to
it's
the
like
opioid.
people.
Because then you use opioids to deal with.
Right,
Yeah,
your trauma.
yeah, or any other
Absolutely.
substance. Yeah, I mean, it doesn't just have to be
Right,
opioids,
or
but
alcohol or.
Yeah.
I mean, it's just all encompassing and it's
Mhm.
just such a level of control and abuse and mind games. It's just
It's
unbelievable.
everywhere.
Yeah, and my colleague from Mahaska County, there was one in Atumwa, one of these presentations in Atumwa earlier this year, like February or March, and I could not go. So
Mhm.
I want to go to this. So anyway, I wanted to bring it up because I know we won't meet again till after that, but yeah.
Is this something you have to register for?
You don't have to register, you just can show up and I have no idea. Let me make this bigger so I can read it.
I think that means if we go, you'll buy.
I think the thing is,
Oh.
like, especially for like emergency department folks, EMS folks, people that are gonna be treating these individuals that are being trafficked, sometimes it's very subtle things that you notice during an
Right.
assessment.
Mhm.
And then you're empowered to hopefully help them or to at least be
Right.
like, to do something,
Mhm.
maybe, so the key points of this, what is it, who's involved, action steps, what to look for, and the seed of all of it. So it's just, yeah, anyway. Free public showing, Hotel Manning, Friday, July 25th at 6:30.
Yeah.
And I Googled grid shock, I mean, and there's a whole bunch of
Yeah,
stuff
Abby's
there.
got that up. too.
Yeah, so anyway.
Mhm. Mhm.
Wow.
Anyway, there's that. And sometimes I get a lot of flack about stuff that I post on Facebook, like, why are you posting, like, people won't say anything on the post, some people do, but like, they'll see me at the store, like, well, why did you post that? Why are you offering that? I'm like, because it's important to have a conversation about certain things
Yeah,
and
get
to
your head
bring
out of the sand.
awareness about it.
That's not
Yeah.
something that should be taboo.
Right,
Yeah.
right, I mean, anyway. That's that.
Yeah, especially at the Diddy trial, it's all out there.
Oh, yeah. Did he, sidebar, did he
Remember,
get
we're on Zoom.
arrested for anything?
I think,
Not
yeah,
cussing,
I don't know,
He did.
I don't know.
which brings me to our newest lawyer in employment of the county. He's pretty good.
Who is,
Mike is leaving
oh,
and they've hired Ed Kelly. He used to be the county attorney. He's worked for the feds. He's done a lot of stuff.
see, if people just didn't do things that were inappropriate, then we wouldn't have to have all those things in place. Prevention is a very important thing. Mitigating things before they happen is important.
Okay, I would like to order a t-shirt.
Ask Deb. Oh, shoot.
Yeah.
I can't think of anything else really. We're busy with other stuff that's not.
What do you guys do over there at your house that's associated with the opioid, that could be associated with the opioid? I mean, we've got a lot of money.
Well, all of the work with the ACT is,
Yeah.
all of that
definitely.
is
Alcohol.
alcohol. Yeah, that's all related to that. I mean, you can't control when we get phone calls. I mean, we get phone calls when we're
Mhm.
referring people. Honestly, we're trying to figure out how all this mental health stuff's working with the new districts and
How's that
primary
going?
care. It's still too new, we're only a week into the new fiscal year and there's a
Mhm.
lot of things that
Mhm.
we don't know yet. And we won't know until you get a call or somebody needs something and then.
What is our district?
It is, I'd have to look at the map. I can see it in my head,
There are
but.
5 districts in Iowa, correct?
Mark, you want to speak to all that since you're working with
I
it?
think I think there's more than 5 because we're District 7 up in like the Johnson area. But yes, I just saw it too, like just the other day. Like, where did it go? But yeah, it's all a learning experience for sure.
Yeah. I mean, I think the thing, I'm Googling it, because I look at so many maps because I have you're probably thinking, why can't you remember that? Because we have so many maps in the health department for so many different funders and so many different things we do, like emergency preparedness, our epi map, our mental health map, our
CCNC.
child abuse consultant map. Every map is different.
No, I swallowed wrong.
Okay, let's see. All right, so
District 6
yes.
is Jefferson.
So we have, let's see, I think this is the most current one. So I'm just gonna start at the bottom because it's easier for me to work at the bottom tier of the counties and then go up. So it's Appanoose, Davis, Van Buren, Lee, Monroe, Wapello, Jefferson, Henry, Mahaska, Keokuk, Washington, Poweshiek, Iowa, and Benton. Does that sound right? Thanks, Kamara. So that's why I can't remember it, because this map is different than any other map that we have for any other services. So,
Yeah, that's a lot that we don't do anything else with.
and I think that it's just, I think for people with mental health needs, I think it's just always been, what do? You call Sandy or you call Leah for years, whether they were county employees as county CPC and assistant CPC, or whether we were in our previous region or district, whatever you want to call it, everybody calls it something else. Those two people were consistent for a long time. So I think it's
Right.
just a lot of unknowns.
Yeah.
And with Southern Iowa Mental Health is the CCHPC, which is like the coordinator of all the services, their contracts with Iowa Primary Care. They have a office now in Fairfield. It's behind, is it the BP on 2nd Street? In those,
Over by,
Yeah. It's on, is that,
everybody's, and then the VP, and then.
there's those office buildings back
One of
where
those.
Fairfield Fire was at. Yeah, years
Right
ago. I
behind
can say
BP.
that to you guys because you'll know where I'm talking about.
Yeah.
So yeah, so they have an office here now. They have stopped by the health department, but I've missed them, so I want to reach out
Are they
to
on the
them.
first floor?
I don't remember what the
I
suite
think
number
so.
is. I think they are.
Yeah.
So,
I want to say yes.
yeah. Anyway, so again, there's all
Who's
these,
in charge of that office?
Christina Shark is the executive
Oh,
director
okay.
at Atumwa for Southern Iowa Mental Health.
Yeah.
Yeah. So there's just lots of moving parts to all this stuff, and it's just,
Do you think it'll ever settle?
no, because it hasn't. In the 30 years I've been a nurse, no, mental health has
God,
always
has it been that long?
Yep, mental health has always been challenging because of the payer system. Even before Medicaid was with HMOs or, managed care, the
Mhm.
mental health component of Medicaid was always managed care. So it's always been managed differently than
Yeah.
traditional Medicaid 30 years ago.
Yeah.
So it's always been different.
And no one's going into psychiatry because there's no money in it. So that's another big problem. That's why a lot of nurse practitioners can specialize in mental health and still prescribe.
Oh,
So, and heaven forbid you need a bed, an inpatient bed, because it's gonna be
Mhm.
challenging. So
well, don't you have an empty room over there?
Nope, it's full.
we have no beds. It's really a problem.
No, it is.
People.
Like,
It's really a
Still
problem.
got them in the basement, don't you?
I have a story. I don't like to go to the basement. It's like damp down there and
That's
creepy.
scary.
No, it's not scary.
Cells are
Spider.
still there, aren't they?
mhm.
No, there's no cells down
There
there.
aren't.
Closets.
They kick
Closets.
them out?
Yeah, there's not cells down there. Otherwise they'd be full. I'm joking.
They're not going to tell us.
No, it's storage rooms with doors that lock.
Oh, I thought the cells are still down.
Mm-mm. Come on over, Joe. We'll take you down there.
The bunk beds are, but not the
That's
cells.
scary.
Joe,
No,
when Chris says, you go first, Joe.
we'll
Don't do
take you
it.
down there. We'll
Don't
take you on
do
a
it.
tour. We'll take you on a tour. We only have one room down there for storage. Everything else is fire department. At one time, Tim Dilly and the county attorney's office had some books stored down there, like law books, and I don't know.
Is it damp down there?
It's kind
Yeah.
of damp.
Because the holes underneath of that on the north side is ours.
No.
Yeah, it is.
Well, I'm just telling you.
Yeah.
There's stuff down there.
No,
that's-
I know.
I've never been down there.
Well,
Anyway,
we'll
so
take
that's-
one tour.
That's
So in
the
other words, I had a
condensed.
successful childhood. I never had to be in jail.
Yes, you probably were upstairs though, weren't you? Where our offices
Yeah.
are.
That's
A
great.
successful challenge. Oh, yeah.
Yeah.
Well, thank you.
I could tell stories.
So that's all I know. That's the condensed version. I just wanted to talk about grid shock and
Well,
mental health
I think
regions
that's
and-
kind of a good idea.
yeah, I'm planning.
I'll
on
probably
going.
try to go to that.
Yeah, I'm gonna try to go. I'm planning on going. Who knows? That's a couple weeks away, which is
Uh-huh.
crazy when you think about it. So
Yeah, where'd
Yeah.
July go? It's already,
I know.
Yeah, no kidding.
yeah.
So when are we meeting again?
Well, it'd be the second Tuesday in August, but do we want to do that?
That would
Well,
be
maybe
it.
because people are getting.
Would be
You're
the
looking to
12th.
count. That'd be the 12th?
That's the 12th.
Yes.
Mhm.
School
Yeah.
probably starts next week, doesn't it?
It's
Okay.
usually the day
Yeah.
after the fair, the state fair.
Yeah.
It would be like it wouldn't start that early.
The
it'd be
teachers
like-
probably have to be
Yeah,
back.
the
Yeah.
teachers will be there.
Yeah, thanks, Abby. It'd be the last week of August. And Abby said the
Well,
20th.
when do you want to meet again?
It doesn't matter to me. I'm just penciling out my schedule because I know I've got some preparedness meetings on the 13th and 14th in Iowa City, so.
August?
Unknown caller.
Again?
At 9 o'clock, is that what you? Well, I'll take care of following up with Darcy for the invoices. I'll email Amy at the hospital about the booklet and then I'll email Talcott.
I think that's a good start to get ready for when we have more folks here.
Yeah.
For their input.
Yeah.
Kamar, do you have anything you want to add? But this is informal, as you can tell. This is about like the ACT meeting. We don't get all formal when we have meetings.
No, but it's been good information because it's hard since I'm not living in the county to really understand like what's going on, like what the population is like. So
Buy her lunch
This
if
is-
she comes down.
very insightful. But yeah, as we continue, so it's a new fiscal year, at least for our grants. So if I'm always available to give those presentations about tobacco trends and then the Quitline program, which providers can refer to. If friends and family, you can talk about like what Quitline is, which is Iowa's free cessation program. So that's mainly what I do in Jefferson. But then again, like with things like this, I do like work with opioid topics, some alcohol as well. So anytime I can be a resource, I would love to do that. And then as another part of our grant, we also work on the state opioid response grant, but just for like Cedar, Johnson, Washington counties and Iowa. We'll have some virtual trainings coming up. And so once that calendar is settled, I can share that with you all. So if there's a topic that you want to learn more about, like you can just join our Zoom and for an hour and just hear more information
Good
about
idea.
more niche topics related to opioids.
Nice. I wanted to throw this out. The next Board of Health meeting is September 11th. We're kind of off schedule because they had an extra meeting, and so it's September 11th. I didn't know if you wanted to present or if you wanted to wait and present like in the spring, because we'll meet again like in December or January, but those, I just didn't know with your reporting, we should meet again. I mean, November, December, January, and then March. So I'm just throwing it out there. So it's whatever you would like to do. You can think
Yeah.
about it, let me know.
Yeah, that might work. It just will depend on, so I also teach life skills, so that's in the morning.
No
So I
problem.
will keep you posted on that schedule. So I'll pencil it in for now, and if that doesn't work, we can push it out.
Okay, and we can always offer a Zoom option too, if that's helpful. Okay, we don't always do Zoom, but if we have a presenter, it makes more sense to allow the presenter to be on Zoom because it usually get 10 or 15 minutes and it's crazy to drive an hour and a half one way or an hour one way for a 10-minute presentation. So, okay, I just wanted to throw that out there. The other thing, when you brought up opioid response grant, the Board of Health did approve the policy for distribution for Clodexo. I would say that wrong, Clodexo. I always say it wrong. How do you say it?
Cloxado?
How do you say
Is
it?
that what you're talking about? Cloxado?
Yeah, Cloxado. It's basically a higher dose of Narcan. It's the same drug as Narcan, it's just a higher dose. So we can distribute both of those now, so there's no questions asked. It's with the state opioid response grant, and all they have to do is come and say, we need some naloxone or, Narcan, and we can distribute it. And we only ask for their zip code, and that's just for tracking purposes. They don't have to give it to us. But anyway, it's ready to go, so. And I don't know, the funding hasn't changed for that as far as I know at this point,
I
so
think it was cut, the program.
I don't know. We still have plenty to hand out,
Sure.
so
Yeah.
I'm not worried about funding
I'm
because
just
I'm
sitting
just
here,
not
Chris,
gonna worry
thinking-
about it.
It's too bad that Narcan or the higher dose
Yeah,
is going to be neat. I need Band-Aids in my house. I also need some Narcan just in
yeah,
case.
yeah,
Right.
yeah.
I mean,
So we
that's
have it now to
just-
hand out.
Is there an expiration date on that?
Yeah, yeah,
What was it, in 27 maybe?
yeah, I think that's it.
Oh,
So it's
sure.
out a ways.
Yeah.
Which is
But
good.
we can't control when we get stuff from the manufacturer what the outdate is. Sometimes you got a shorter window for outdates and then it's just wasted, which is unfortunate, but
Yeah.
anyway,
Yeah.
so we have it available.
Do you have requests for it?
I just got the policy approved at the last Board of Health meeting,
Okay.
so, I mean, we've been on the state's website as a pickup site. Some counties have like a dispensing unit where you don't even have to come in, you can just like get it and, that's a whole, we're not doing that. That's an expense and we're not gonna do that. They can just hit the button, we'll give it to them and no questions asked, just like if they pick up condoms or something like that. Psh, here you go.
Mhm.
Be safe. Go to the world and be safe. So, yep,
Not even a comment.
yeah, so there's that. I think that's it.
So when's our next meeting?
I thought you said
No, I don't, I
Oh.
can't remember what we said.
August 12th at 9 o'clock. Is that right? Yeah,
Mhm.
Okay,
okay. Is that right?
Yeah.
Okay, it's in the dark part of that calendar thing, so I'm like looking at it. trying to
no,
see.
it's on the
Yes.
12th.
All right,
12,
all right. Okay.
Second Tuesday.
Kamara, thanks for joining us.
Yeah,
Yes,
it was
thank
really
you for
nice
the
to
invite.
get some input.
Yes, yes. I'll talk to you soon. You know how to find us, okay?
Yep, got it.
All right.
All right, have a good day.
Bye, thank you.
So out of curiosity, have you driven the ambulance out on Pleasant Plain Road yet? How to do?
Oh, not recently.
Oh, okay.
I was on a call up there months ago.
Okay.
There she is. State's.
I drove on yesterday.
Yeah. What do you think?
Oh, no, it's Sunday, I'm sorry. Sunday. I drove. No,
I drove it out on Saturday. I thought it was pretty rough. Now, Jervis, or not Jervis, Dow's Road, yeah, it's straight.
That's it.
Lock Ridge is.
Yes.
Okay, I thought.
Dangerous.
Yep.
Boom.
I don't know what.
No, last time, sorry.
So we hear anything back from the customers or?
Finney's, right?
Finish, yeah, finish.
They got one for 7,500. Which is a lot less than I thought it would be.
Yeah. Does that include the striping or you know?
I don't know. I assume so.
Of course, you know, we might get it cheaper for the red stripes. Just saying, you know,
Wow.
use whatever stripes they have in stock.
Oh, so she's with the billing company as well.
Hi, good afternoon, everyone.
Hello.
Hello.
That's our billing company. right?
Hi. Yes, this is Chelsea Mock, your CSE, and we have Kim Stanley with us today if you'd like to introduce yourself.
Sure. My name's Kim Stanley, and I'm the Chief Client Advocacy Officer. I was the compliance officer until January. So been with the company for about 23 years now. Nice to meet you all.
Appreciate you being on.
Yeah, absolutely.
Oh, excuse me. Are we at, past 2:30? So we'll go ahead and I guess call the meeting to order. Since we're on the agenda, we are on Zoom. I think what we wanted to do is the board, since we're no longer an annual service agency, we want to have a discussion and questions, and I know that we've had some communication late with the hospital regarding transfers and stuff, so I just thought it was a good idea to try and get everybody kind of on the same page, partnership type relationship to see. Yeah, I mean, you and I, and forgive me, I can't remember the new financial officer's name,
Brent.
Greg. And Josh had a conversation here a while back, but, so Josh, I'm gonna open it up to you to start, and then we'll go from there and feed off of you. And I know we had a concern, or not a concern, but a difference of opinion, maybe it would be, regarding a transfer to Mayo Clinic here a couple of weeks ago that we opted not to take. Josh and his expertise thought that it wasn't the best option. I had been financially, but not necessarily under the circumstances, and I'm not a doctor, and so I don't get involved in those, but we do rely on the director of operations to make those decisions if they need to be made, and in consultation with the medical director. And so I just wanted to be sure that it wasn't, I don't know what term to use. I don't know. It wasn't a professional dispute. It was what he thought, in his opinion, the medical director's opinion, was the best way to proceed. I don't know the circumstances with the patient. It's not my business to know the circumstances with the patient, but anyway, let's just go from there.
Can I just make one comment really
Sure,
quick?
yeah.
That's okay.
Yeah. Did you buy a ticket?
I did.
Okay.
I punched it into that
Okay,
calculator.
okay.
Obviously, we're in a kind of transition time from the board
Right.
to more of a slightly different partnership. And I just want to make sure it's very clear that from JCHC's standpoint, we're very interested in having a very positive working relationship. The patients that we have are the patients that you have in these cases, right? And so we are very interested in making sure that there is positive open communication and that we understand kind of what to expect on our end when it comes to transfers specifically. And so we appreciate the opportunity to come in and just talk through things. That's the best way to me, is get everybody around the table and just talk through what's going on. And so we appreciate the opportunity, and we're very interested in moving forward in a positive light.
Absolutely.
So,
And Stacy and I, we talk a lot. I think about just all different things. I think we have a pretty good open line of communication. I have a pretty good relationship as far as talking about things. We don't always see eye to eye on things, which, that's just going to happen. It's the nature of the beast. Going back through, looking at everything, I think through complaints, through staff complaints and things like that, and just the griping that comes with that, there seems to be a lot of nonsense about transfers and things like that. Looking at objectively going through the list, in the last, well, I went back to January, we found 16, 18, I don't remember, transfers that were like questionable. And so we've kind of, I've got this here if you guys want this, but from my perspective, and things like the Mayo trip at 2 o'clock in the morning, I know that did ruffle a lot of feathers, and I understand that, but in my mind, it's not safe to put a crew on the road at 2 o'clock in the morning to drive 9 hours. And I know it seems like, I hate to have conversations about money. That's, as a medical provider, that's like the last thing I ever paid attention to when I was working the streets. But to me, it's more about crew safety and advocating for the patient than anything else. so the list here, again, this is what, most of what we came up with. I threw some out that were like right on the fence, that could have been questionable, but like, But these are the ones that really kind of stood out. And as far as like questioning the reasonableness of the ambulance, I think that is my biggest issue. CMS has very explicit rules for what justifies an ambulance service. I know you've seen this, but if you want another copy, I don't know if you want that or not. CMS, Center for Medicare and Medicaid, has very specific rules about what is medically medical reasonableness is what they call it in the use of an ambulance. And when we compare the spreadsheet to what CMS outlines, there's again some questionable trips going out. And again, this is a conversation that we've had multiple times, and I don't know that we'll ever actually come to any sort of agreement. Because again, we look at things from a different perspective. I'm looking at crew safety and sending patients out at 3 o'clock in the morning on.
To be fair, Josh, we can disagree on that one all day long. It doesn't matter. But the piece that ruffled the feathers wasn't just that piece. It was everything that happened within that.
Like I said,
to me, the Mayo thing, like it's a once in a blue moon. And like we can spotlight that one, but that's the wrong.
I know
spotlight.
it is because there were a lot of other things going on that night that I was not aware of.
Yeah.
But you handled that internally with HR. I mean, all of the things,
there were other things, there were other things at play there that in the moment I wasn't aware of, but you're not wrong.
Right. I mean, the Mayo trip is legitimately, we send maybe 3 patients a year to Mayo.
Right.
So having the conversation focused on a Mayo scenario doesn't do us any justice to the patients
most
that
of
are
what we're talking about.
right.
Yep. So and you guys can see this and kind of why we question it on our end. And as far as payouts on these, I do have that information, but again, I didn't include that in here. So I guess from my perspective, and again, looking at it objectively, 18 trips out of the hundreds a year that we take isn't horrible. But still things can be addressed on that front to find other methods. And again, I'm looking at it from the perspective of crew safety. And I know it's, one of the retorts I hear a lot, or I've heard a lot over my career was, well, you signed up for it. 24-hour shifts suck for anybody. And questionable transfers don't make that any easier on anybody. So,
well, I'm gonna, as a layman here, I'm gonna jump in here, and I don't understand any of these, so, okay. And that's fine, that's probably better that I don't, but when we send a rig out of town, I don't want to say this, that when one apparently really wasn't needed based on what I'm looking at here, then we take that rig out of service for all intents and purposes. And so then we're down to 1 rig. And then if there is a serious need, not that these patients maybe didn't think that it was a serious need. I don't know how to explain this. It seems to me that I'm looking at some of these that are going, like I pay to the university. So we take an ambulance out of service, transfer a patient with an eye pain to the university, when potentially there could be something more serious come along, and we've only got 1 rig and we can't transfer.
Sure.
And I think and I hate for money to be part of the equation as well, but by the same token, obviously our people are still on duty, whether they're taking a transfer or whether they're not, so we're paying them, and I get that part of it. But I don't have the expense of the fuel
Sure,
and,
sure.
and all of the other, as well as this, you guys are well aware of reimbursements in certain capacities. Might as well not be a reimbursement, but I'm concerned that if we're sending a rig out of town for reasons that they don't need to be using an ambulance, and I have to rely on the professionals, which is all of you, because I don't know, one or the other. When a patient could go by personal vehicle or whatever the case may be. I don't see that as being beneficial to the residents overall. If a serious, I hate to parse which ones are serious and which ones aren't. I don't know. I'm going by this. If we have a situation where we got a rig out of town because of a toothache, hypothetically speaking, and we have a major automobile accident or something, and we've only got one rig available. Now, we can bring in a crew. Right now, we could bring in a crew, but we don't have a rig to put them in.
Right. And, to play devil's advocate there, that's a risk always.
Sure.
I mean, you could have 3 crews in town and still need more at some,
And I get that, but what I'm saying is that when you send a crew out of town for a emergent situation, that they could go by other means. That doesn't look like good business to me. And when I say good business, I don't mean in terms of financial
So
remuneration.
can I
Sure.
interject just a minute? So I would love to have a conversation, but based on this information, because Josh and I have went over charts multiple times where he's like, this isn't appropriate. And then when I look at my documentation, like our patient that had a small bowel obstruction, who truly was who also had a C-spine fracture, who also had all of these other things that wasn't duly noted in the documentation, like there's a reason that those went. I can't justify any of these or talk to you logistically about any of these because I don't know, like I didn't have an opportunity to prepare and know what charts there are.
right.
Like to me, a jaw fracture, if anybody has a jaw fracture, it's probably trauma related. And they were probably accepted by the trauma team because it takes a lot of force to break a jaw. Like there's very few jaws that are just a jaw fracture. So if they're going for a trauma evaluation and the only thing they ended up with out of it is a jaw fracture, to me, they probably would have had pain meds ordered. Whether you gave them or not is a different story. Like there's a lot of other pieces that we're not seeing.
I'm seeing patient request a personal vehicle.
Right. And were they intoxicated? Were they?
I have no idea.
Right. That's what I'm saying. There's a lot of other things that.
But by the same token, if this documentation doesn't show this, and then he does something en route that on the documentation, and I don't know, I'm asking this in the form of a question. If he does something en route that there's no apparent need for in the documentation, then what does that do? I don't know. Does that become problematic? Is it?
I don't understand your
Yeah,
question.
I don't.
Well, so I don't know. You said something about.
That patient isn't even on here because we got rid of it because the documentation was
Right,
there, it
but you
just
said-
wasn't on.
Okay, so I'm gonna go with the bladder obstruction. I don't know. Something in here, what you were talking about, where you said that some of the stuff that you talked about when he gets to you, that your documentation is more definitive, I'll put it that way, than what is being expressed. And my question is, if you don't have that documentation and something occurs en route and you provide medical treatment for that, but it's not documented, is in information you get, is that problematic?
No, because
Okay.
if we're doing anything, it's going to be responsive to what the patient,
Right.
what's
It's in your
going on with
standards.
them. Right. That's going to be within our scope of practice and within our protocols. So that in itself is not an issue. And again, yeah, the documentation piece, and she's not wrong. We've had multiple conversations about this.
But why are you
And
not
we're-
getting that documentation?
Well, when we show up, we get a verbal report from the nurse,
Okay,
and then we take that information, and typically there's a transfer packet, a packet of information that goes along with us. That I can tell you what I do. I go through it and find pertinent information, whatever I think is relevant, but not everybody does that. Which again, I'm working on some of the documentation piece internally on my side, so we can help mitigate some of these things as well. Because yeah, all I see is, right, half of the
Right.
picture. And again, those are conversations that we've had several times.
so let me ask.
So,
Okay, well, I was just gonna say, and this is the least of our concerns on one level. By the same token, the documentation isn't there, and this is what we're getting. When it comes to filing the reports that go to the billing company, are we not having the same documentation? Does that change the way that we charge or what we charge for?
Well, so we charge for basically what care we provide en route.
Okay.
So, or we get reimbursed for what care we provide en route. So and again, it's also based on what they believe is relevant. So if we have a jaw fracture, this guy, he didn't have any needs en route. I was told that he requested to go personal vehicle by friends or somebody. I don't know. No pain meds, no anything given en route, but he was on a cardiac monitor with no cardiac history. So things like that, like how do I justify a cardiac monitor on a patient with no cardiac history who everything else was clear, but he had a displaced jaw? Like those are the things that the insurance company is going to read that and be like, why?
Right.
And again, what we see as common sense, and I'm not questioning that any of these needed to go elsewhere.
So I can tell you the other piece of this that we've talked about in the past, and that doesn't help you or help anybody else, is the responsibility of the ER physician and the hospital is to make sure the patient gets from point A to point B safely. So until they are dropped off at the next level of care, it's our responsibility to make sure that they go in a safe manner. So any physician is going to tell you, and to be fair, we do send quite a few transfers by private car that we don't like to. But because we don't want to have this conversation, right? So where someone will say a hip fracture doesn't necessarily need anything because they didn't get pain medicine en route. Do you want to be sitting on a broken hip going? And if that person that's driving you from point A to point B gets in a car accident, that's on us legally. That doesn't make it your problem, but I will tell you that is why the medical community tends to put people in an ambulance or want them to go in an ambulance, is because it's deemed a safer method of transfer. Just like we talked about at our meeting in May, there's no acute transfer that we can discharge from the hospital and go to an acute level of stay. It can't happen. Because insurance won't allow them to be an acute patient up there. They'll have to go through the emergency department and do all of those other things. When you have an acute patient that has a need greater than what we can provide at Jefferson County, and they're going to an acute level of care somewhere else, they can't go by any other means other than by a medical transport service.
And yeah, EMTALA plays into a lot of these things as well. And again, we're all fighting from different perspectives because the system is just
Right. None of it speaks
broken.
to each other.
No, it doesn't.
Hey, this is Kim Stanley at EMSMC. Can I jump in real quick? And I only do this because I have another meeting at 4 p.m. Eastern, so I will have to jump off in about 10 minutes. But I think I might add a few things to the conversation, and I agree with everything that everybody has said. Let me come back on video. I didn't realize I turned that off. So yes, I mean, it's our job to protect the county in terms of making sure that transports are medically necessary. And honestly, from a non-emergency, most of the hospital to hospital interfacility are going to be considered non-emergency. That they're not a 911 call. It's not a trauma situation that's happened. They're been stabilized. They're going to the further facility to receive that care. So important to us would be the physician certification statement. And I reviewed a few of those before our call today. And they look valid, but that's kind of, if you were looking at the PCS form, those are the reasons in which an ambulance transport would be medically necessary. One being bed confined. They can't get up from bed without assistance, can't ambulate, can't sit in a chair or wheelchair. That's a small population of individuals that meet that requirement. But if they're not or not bed confined, we have another term which is stretcher bound, which means that they can only go by stretcher. And the reason for that stretcher is important to us. That's what we've got to justify to Medicare. And, it's not just the procedure. And I read one report today where it said the patient needed monitoring. And I think even in the paramedics narrative, they said, why does the patient need monitoring? And I believe their response was just because. And they're not, from my perspective, from a billing side of things, I mean, just because they need an EKG or just because they have an EKG monitor doesn't automatically mean that they needed it. And so what they're asking for in those questions is to help prove that medical necessity so that we have something to bill on. So just an EKG monitor by itself does not necessarily mean they can't go by ambulance. We need to know why the EKG monitor was needed en route. Now, if they need EKG monitoring, they're obviously stretcher bound. You can't take that in a private vehicle, and then that helps us to determine medical necessity. So those are the types of things we were seeing. And when we don't have enough information, we have no medical necessity to base it on. We have to file it as a non-covered service. And I've seen some notes in some of the trips that I reviewed where, the patient's struggling because now they're responsible for the bill. And so it starts a chain of events, so to speak, when we don't have enough information to bill. So I'll stop there and see if you all have any questions for me before I have to hop off. I believe Chelsea and Ann, are you able to stay on a little bit longer?
Yes, I am.
Okay.
I can as well.
So if you don't have enough information to bill, do you return that?
We do have a process to return it. If it's not medically necessary, then we'll bill it to Medicare as not medically necessary. And we look at that by saying patient was ambulatory, they were walking around, they were able to walk to the stretcher, or those types of things. If it is something that's questionable, like, in other words, I'm not going to return it and say, hey, change this PCS form to make it medically necessary. But if it's missing information or if it's unclear, if we've got questions, we do have a process where we can return it back to the county and then they can provide us additional information. And we could set that up, with you all as well. We do have, and the other thing, as I said, I've only got about 4 minutes, but we do have a process in which, and I don't know how. Again, I'm the outsider looking in here, and first time I've been involved in these conversations. We do have contracts set up with some of our EMS agencies, and it protects both parties. And I hope I'm not speaking out of turn, but we have a concept called payer of last resort with some of our hospital systems. And what we do there is that we try to file absolutely everything we can as medically necessary. If we've got the documentation, we're keeping them compliant. If we run into a scenario in which we don't believe it was medically necessary, or we don't have enough information, we'd have that feedback loop where we'd ask for more information. But if it wasn't medically necessary, the hospital then becomes responsible as the payer of last resort for that trip. That protects you from a liability standpoint. And I hear you saying we're not putting these patients in private vehicles because the liability is too great. That unfortunately isn't creating medical necessity for us just from the terms of liability. Now, certainly if there's a medical reason why, then we're going to file it using that. But But I want to throw it out there because we do have that arrangement with quite a few of our agencies in which the hospital's partnering with the EMS just to ensure everybody's getting paid and that we're meeting the needs of both parties. I'll stop there and see, do you all have any questions for me?
I don't know if that's an option that the hospital want to consider.
I mean, if we're talking about 18 transports, and I don't know the numbers, like I said, I've only viewed a few on our side, but it might be a viable option, but I'll leave it with you all to discuss further, and it'd be up to you all to come to an agreement like that.
Well, I think the bigger question I've got, and it's just a question because obviously you use the term medically necessary, and I'm sure the hospital looks at it in that context as well. But I'm curious as to how many we've had to bill, for lack of a better way of putting it, where it was determined that it wasn't medically necessary. I think to me is the bigger question in that regard is not so much what the issue was, the patient complained, as much as however it's, what do you call it, the patient certification?
The physician certification statement, yep.
Okay, and so if the information on that form is not definitive enough to make the determination that it was medically necessary, then like you say, you kick it back and say, hey, did they stand on their head in the corner? And if so, when did that happen? So you can fill that information out. But if that information is not available, or apparently that's not the case, so I'm curious as to how many, which were determined that they needed to be transferred by ambulance for whatever reason, but from a billing standpoint, turn out not to be medically necessary.
Yeah.
So our reimbursement is reduced.
I don't have that number ready for you right now, but I can definitely get it. That's an easy report, and Chelsea can put that together for you just to let you know what your percentage of trips that are hospital to hospital from these facilities are considered not medically necessary.
Because I would assume that you would know, like not off the top of your head, the actual number, but like, are we within the realm? Because you do this a lot, right? Like you bill for several services. So like, are you looking at these and going, oh my gosh, this is a large percentage compared to the rest of the population that you serve, or like?
Yeah, and I just
I get
don't
what you're
know.
saying.
Yeah, I don't know that number right now, but I can certainly get it for you. And we can trend that too, for sure. Like that's something that we can tell you, as compared to other agencies, what your percentages are. I was going to share, well, it won't let me share, but I can send over, and you're very familiar with it. It's the PCS form. That's part of that packet that you talked about. But it's meant to kind of be a step by step. So it's asking all those questions that I asked before. So is the patient bed confined? Yes or no? Can they go by other means? Yes or no? And then there's a whole list of other things that potentially might meet medical necessity, but those are taken from the medical guideline or Medicare guidelines to say, they're unable to sit in the chair or wheelchair due to the decubitus ulcers, or they needed oxygen that couldn't be self-administered, or, the patient had behavioral health issues, altered mental status, those types of things. Even your hip example, which I would agree with, a hip fracture doesn't need to go by a private vehicle. One of the selections there is some type of orthopedic device or some kind of special handling that they needed due to that hip fracture. But as long as all of that's documented appropriately, then we should be able to bill that as a medically necessary trip.
Correct. I would also add to that the ambulance trip report, what that looks like too in relations to the physician certification statement. They both work together.
So would it help to have a more detailed PCS? I mean, I know the PCS form is kind of standard. Would it
Yeah.
help to have something with that more accurately or more objectively justifies those things? I mean, and
Yeah, and I mean, all of
I
that's
know
taken
this-
into consideration. And I looked at some of the packages that we had. The EMTALA form sometimes will give us more information because not only is it medical necessity, but we got to determine do they need to be moved. And I'm sure you're not moving them for the heck of it, right? Like
You
what's
can't
what's
move the ones that need moved, so
Right,
no, we're
yeah,
not moving
exactly.
the ones that don't have to.
right. The ones like not only do we have to justify the medical necessity, but needed orthopedic surgeon that was not available, or needed ICU bed, or what, like very specific that way. And just like Ann said, we kind of look at the PCR and the PCS as a package. It's like they should reflect the same patient and should be, shouldn't be contradictory, but that they kind of supplement each other. And I haven't seen any contradictions necessarily, but we just need to paint the picture.
Well, and I want everybody to understand, especially Stacy and Brian, that they speak for myself, I assume the other two are laymen as well. We don't know this industry, okay, we use it, Lord, I've been used it multiple times. But you're strictly looking at it from our perspective. When I like to use the term being in here as a supervisor, it's a lot different on the outside looking in than it is on the inside looking out. And that applies to what you all do as well. So we're looking at it from the outside looking in, you're looking at it from the inside out. And so we're just trying to understand, and I hate for it to come down to this to a certain extent, but it does. So we're looking, for example, that we got $1.5 million in this operation. And if we're generating 720-something thousand in this last fiscal year. So we have to come up with $750,000 plus from other revenue sources, which are thankful to the voters that they're helping to augment that. What I'm saying, or what I'm thinking is, the last thing we need is to provide services that we can't get reimbursed for if there was some other method that would have worked. And I'm saying if, or providing services and we're not getting the full reimbursement that might be available to us on our end because of whatever that might be. And then I gotta have to leave it up to you all, because you're the professionals, you understand all of what she just said, to ferret out a way to make that happen. Because if we're getting a nickel and we can get a dime, quite frankly, I want the dime.
Sure. And we want you to have the dime.
Yeah.
I mean,
Yeah.
So to go to the question of the arrangement, I mean, the first thing I'm gonna see is how much are we talking? Meaning, how many cases in a year? Are we
Right.
talking about 15 cases? Or are we talking about 500 cases?
Right.
Right? So
Right.
that would have to be part of that discussion. As far as like sharing of documentation information, I don't think we have any issues with making sure you have the information you need to do your billing.
right.
Right.
And if there's someone that's just like on your side, if there's someone that's not giving, like consistently not giving you something, I need to know that so I can fix it.
Yep.
And part of the problem that I face, and I'm sure you face the same thing, or maybe, I guess, I don't hear about things immediately. It's like 2 or 3 weeks down the road. Oh, did you hear about this? And oh, no, but
Right.
I need to know right now so I can address it. But yeah, and again, we've
Well, and I think the
had
nursing,
multiple conversations
right.
on some of these things, and
I mean, I think we all agree, even the nursing homes agree that returns to nursing homes are not medically necessary, but sometimes they're a requirement based on the needs of everyone else. And per that meeting, it sounded like, I don't know how many we don't do a ton of them, but they're willing to pay cash for that patient to go back. Right? So, I mean, that's an avenue
well, the
to,
two that were there.
well, Addington's not going to, because that's that's an assisted living, so that Medicare doesn't pay for them to live there. But I'm saying the nursing homes have a different scenario. Addington has a different payment structure. So I mean, I can guarantee you that's not gonna happen, just based on how they get paid.
Yeah.
But like, even if though we don't do that many, even if you reclaim $400 or $600 a month or a quarter, that's $400 or $600 that you have that you didn't have. But I mean, so those, like, I get, but I guess I'm just trying to figure out like what the rest of it looks like, because I want you guys to be able to bill for everything that you can bill for.
Another, and again, going back to the PCS form and some of the issues we've had there, and as I find them, I bring them to you. But again, another complaint or obscure discussion that's had is patients getting IVs with like TKO fluids just to justify the trip, or those kind of things. And again, this is the list of, okay, well, clear cut, or the ones that were removed from this list are some of those kind of questionable, well, they started IV just to justify the transfer.
Or did they have the IV, we gave them fluids, and now we TKO'd it because they've had their max dose of fluids. I mean, I don't know, but I can't tell you that
right,
without being able
the
to look at the
specifics of the
case.
case, exactly.
Because I do know that happened once, and like I said, that's been almost a year ago, year and a half
Some of
ago,
these,
so
yeah,
like,
yeah.
I feel like we can't continue to talk about the ones, right?
I know.
The zebras,
Yes.
we gotta talk about the horses.
It's a good way to say that.
I mean, in Africa might be a different story, right?
Yeah, well,
Then you
sure.
talk about the zebras, but I'm just saying, like, the one-offs, there's always one-offs. And we're happy to talk, I'm happy to discuss every single one of these if I know which patients they are. And like I said, there are times, and you and I will continue to agree to disagree on certain things, right? Because we don't live in each other's worlds. But for the most part, typically when we look at charts together, we go, oh, both of us are like, oh, well, that makes sense. That's right. Like, that makes sense.
So let me ask a question then. How do we get, when you look at the charts together, okay, yeah, that makes sense. But it didn't make sense to you two looked at the chart together. How do we get it so that it makes sense without you having the two of you have to look at the chart together?
Well, I think it's a process issue. And again, I don't know if we can modify or add to the PCS form and make a more formal report process or something along that lines.
I'm happy to,
Yeah,
do whatever we can to make the process work.
right. So
To me,
it is a
It
process.
just seems to me like, obviously, you two, and you understand what's going on, and you're both professionals, and I get that. But at the same time, I don't think the two of you should, I'm not saying there's anything wrong with you coming together to look at these things. I'm just saying, I don't think, in either case, you need to have the other one. It should be apparent. I would think.
You're not wrong. It should be.
Well, but
I think that's why the value of the PSA, right, is if the information should be included on the sheet.
Yep,
And then there's no need to review charts together
right.
on every single one, right? Periodic is good, right?
Right.
That's appropriate, but it's really getting the information that you just need.
But in your PCS, or not your PCS, but your patient care report,
Mhm.
are you having to answer a question, why were they on cardiac monitors? Like, is that, like, I don't understand where that question came from that she asked. Is that something that you answer on every single one?
No,
Okay,
it's just when they look at it, they might have that question.
right. And
Because
so
it's
then
not
they send it
clear.
back to you?
in some situations, yeah, I get a lot of reports kicked back for various reasons.
Right, because when she said just because, I'm like, I mean, there's a myriad of reasons why we put people on cardiac
Right.
monitors, whether they have history or not.
Right.
But
But I
if
mean,
that's
if
the
that was-
answer,
If it was just because to justify the trip, then again, from from billing perspective, they're gonna be like, that's not,
right?
yeah. So,
I can also speak to that. This is Ann. I'm a compliance analyst with the MSMC. And I know I've been a part of various audits where the insurance company comes back and is trying to downcode something because they don't believe the EKG was justified. So sometimes, I mean, some are obvious, you've got a cardiac patient, they're on a monitor, those kind of things. But ones that just aren't as clear, those are the ones that are questioned.
Well, it would seem to me, and I understand, I get from the outside looking in, but it would seem to me that it would be definitive on this PCS form or whatever for the need for that cardiac monitor. Well, what I'm saying is, it seems to me it should be there. It should be defined as to what the need is.
well, to an extent. And again, we can look at that and be like, yes, that's common sense, that there's a reason for it. But the PCS form is just a lot of checkboxes. And there's not really any justification
There's not a lot of.
or explanation for why they need things. And again, this is one of those things, and I know, like, we question the providers to ask why we need this thing, and then the providers get upset because we're questioning their authority or whatever. Like, we just need to know why we're doing what we're doing. So I think if we just add another sheet or whatever, it's another step for you guys, which is a pain, but if we can get clear justification or modify the PCS form to allow that space for objective clarification on it.
Well, I guess
Because we don't add the nursing report in our documentation.
Okay.
We write a narrative. We go through like 10 pages of checkboxes, and then we write a story. And generally speaking, I think it's typically that story that is what the billing looks at with a couple other pieces in there, and that's where they get the information from.
Right. And so for me, when I do a documentation, I write your story. Like, I write what you give me in a report.
Right.
Like, that's in my note. And then we do all the check boxes, and then we have our story of what happened. So, but there's a huge missing piece if I don't put your EMS report in.
Right.
Because someone comes in you ask them what they're there for, and they may say, I think my mother-in-law had a stroke. You bring me the patient, I ask the patient, what are you here for? Oh, I don't know, my head hurts.
Yes.
But if we're not capturing the true picture of what really happened at the hospital, then you're missing a huge piece of what potentially gets you paid.
Right. And some of our staff do really, really good as far as asking the questions and documenting the reasons very explicitly. Others not so much. And again, that's an issue that I'm working on in-house, but.
I'm just saying, there's a joke in healthcare, right? Like, for every person that you see, whether it's the front desk person, whether it's the nurse, whether it's the doctor, whether EMS is thrown in or not, you're going to get 4 different stories, because every person you talk to gets a different story from the same patient. And so if you're missing a piece of that, you're going to miss a potential billing opportunity.
Right.
Because if we gave them blood pressure medicine, we're probably going to want them monitored for their blood pressure, because an hour down the road, if it was a PO med, it can tank.
So my question is then, is it appropriate? Well, I don't know if it is or isn't. Is it appropriate for the doctor's notes to be attached to the PCS form rather than creating a new PCS form?
It may or may not be completed.
That can be, well, that too, but that can also be very cumbersome.
Well, Chelsea. The reason I asked the question was just simply because if there's somewhere along the way, even if there's and I get where when a doctor says, yeah, this patient has to go, we're sending Joe up and he needs a cardiac monitor, you know, and he's telling you, our folks that, right?
Mhm.
Okay. Is there some way to document that in that conversation as to, because when they go back, I guess my question is, so that when our folks go back and sit down and do their report, we used a cardiac monitor, why? Because that's
The
what-
doctor doesn't, the doctor says so, doesn't get you paid.
Right,
Right,
That's the problem.
yeah. And so that's why we need
Like,
something brief but objective to explain the why.
and yeah, and I just, that's why I thought maybe since the doctor was writing notes anyway, or somebody was, the nurse or somebody was taking, you know, and I realize you're right that they usually go, I watch my doctors when they get done and they'll go sit in office and they'll record
mhm.
what they did, so
Right.
the notes aren't necessarily readily available, but I would think that, you know, like writing a prescription, so to speak.
So as far as for today, I mean, the getting you the information that you need. Should we start with that?
Yeah, I'm
As
happy
far
to.
as trying to help provide information for you so you guys can do the billing that you need to do. We don't want to be the barrier of your billing. But on the flip side, from our side, we don't want you to be the barrier of our transfers.
Right.
And that's the frustration on our part. We have a patient in the ER who's there and we have a place for them to be. We have no way to get them there. And that's what takes our staff off because they busted their rears off to get that placement. And to have everything care-wise for that patient. And now we're getting grief from the ambulance service sometimes. Because we're trying to transfer through an ambulance. And so what we're willing to do is make sure that we tighten up on the information that we're providing you. What we are requesting from you is do your internal, like you've already mentioned. Do your internal communication with all your staff, make sure they're documented appropriate. Because it sounds like there's some loose ends on that one. And then we would really love to see less barriers. That's what we ultimately want to see on our end.
And I agree. I think, and personally, the frustration on our end, I think, as far as the transfers go, we had, was it last week before, a crew was out, took a patient to Iowa City. From the sounds of it, the ER staff was upset about us not getting back in a timely manner. Let's take another trip. Like that's where we get annoyed because the hospital has zero vested interest in what we do, and yet they want to treat us like their taxi cab.
Sure.
And so,
And I'll tell you, from our staff's perspective, you're right. And this is going to sound wrong when I say this. My staff does not think about the ambulance employees. My staff thinking about the patient that's in their bed. That's what they're thinking about.
yes,
And so whether somebody is on a 24 shift, that's in your guys' control of what you do staffing wise.
right.
So that's your issue.
It is,
But my patient,
but
yeah, our
when,
patient is in the bed.
yeah,
That's what we're thinking.
and I understand that. And again, it's different perspectives because when in inclement weather, when the nursing staff is trying to push and push and push a patient to get out the door, but they're worried about how they're going to drive home. There's
But
no.
we created a policy for that, right? I mean, we have
Yeah, we
that,
have an inclement weather policy,
right?
but it's still, and again, yes, it's what EMS signed up for. But I still have to look out for my crew safety. And that's the piece
Right.
that we clash
Just out of
on.
curiosity, what do you guys propose we do with the patient in our ER? If ambulance doesn't want to transfer?
Well, I guess, that, you know, I don't know that. I don't know how often we refuse to transfer as far as that part of it goes, but the other side of that coin is, we send a rig up to the Mayo. And I realize that happens once in a blue moon, I get that, but my point is that once that rig's out of town, and we have one rig for 911.
But Lee, that's the same instance what happens when we go cover Eldon's Fair and there's not a third crew to do that, then My transfers that are sitting here can't go until someone's back from the Eldon Fair if there's not a third crew on. I didn't come up here and jump up and down about that, but the reality is when we're told, yeah, sorry, we're gonna go cover another county's fair, and I have patients in my ER that can't get transferred because we don't have a third crew, that's really frustrating.
And if the hospital, with all due respect, was to help cover some of those costs, we might have a third crew. But again, I just said, we've got $1.5 million in this, and the hospital's not putting a dime in it. We're saving you $500,000 a year, let's remember. That not meaning you, but Care Ambulance wanted $1.5 million to do this, and you made a statement the last meeting that we had that my board, your quote, my board said that if the county takes this, they take the good, the bad, and the ugly. Well, we're taking the good and the bad and the ugly. But we also have a limited source of revenue as well, not only in the ambulance, but what we have to run the county with. And we're running 24-hour shifts, you're right, that's what folks sign up for, that's how they get paid. They get paid overtime, all of that stuff is in there. But the reality of the situation is that we can't put a third crew on. We have 3 ambulances in the event that we lose one, which we've lost one. Okay, and those, as you're well aware of, you part of the process, so were you. This last one that we purchased was $260,000 and it took us 2 years to get it. Well, that's not true, about 1.5 years. But irregardless, my point simply is that it's in a perfect world, we could have 5 crews. I mean, I don't know what Henry County does. They got 5 ambulances over there. I don't suppose they staff them all. I don't know. But my point is that we aren't generating enough revenue to put on a third full-time crew.
That's not what I said.
I know that, I understand that. But the fact is that, you know, we can have people who, when they're at the fair and they take the older ambulance or whichever ambulance they take, it doesn't matter. You know, and they can work those arrangements, and I get that, and we could still have 2 ambulances on staff or on, you know, I mean, if we're getting enough money, and I'm saying if we're generating enough revenue to do a fair or something of that nature, it should cover the cost of a third crew if they're available. I agree with you in terms of, you know, being out of town as far as that part of it's concerned. But it's also been a sticking point of mine, and Brian knows this because we've had the conversations before, that we took a huge financial burden, in my perspective, off the hospital. And we haven't asked you for anything other than the last conversation we had. I asked for $50,000. But again, we took $500,000 out of your budget. Because that's what Care was going to want to have to stay here, including the subsidy. And we've taken on the entire burden. We get nothing from the city either. And we're happy to take on that burden. But we can't, how do I want to say this? We are, with limited resources, we're limited on what we can do. And so we try to find revenue in other places. And sometimes I get it, you know, inconvenience is not the right word to use when it comes to patients at the ER or whatever. And we can do better in that regard. I think we can, in terms of if we're going to do that, we should be able to put a third crew out there if a third ambulance is working, and that what we're getting from, say, Wapello County Fair should cover the cost of that third crew.
Which that would be ideal. The issue there is they need confirmation well in advance.
Right.
We get a contract with them that says we will provide an ambulance here, here, and here. And if we can't muster that third crew, we have to send whoever's there. And it is an inconvenience, and I understand that. But when we've had a contract and it's guaranteed pay versus hanging out waiting for the hospital, maybe something will come up, maybe something won't. It's a trade-off. And again, you know, without, you guys have zero vested interest in what we do, yet you expect us to just hang out, wait for a call.
Yeah, that's what we do.
Like,
We have staff sitting in the ER waiting for something.
yeah.
That's what we do.
right.
So we're not asking anything more of you than we do ourselves. We sit there and we wait. Yep, that's true. So I think what I can basically just listening and trying to find some ground that we can start moving on. It sounds like the PCS, if we can do some documentation, additional documentation for those transfers to help you in your billing side, that would be helpful.
I would also really like to know from their standpoint, how many were considered non-medical.
I'll find.
You know what I mean? Because if
That's
they
the other-
truly weren't, if there weren't that many, then the reality is changing that process isn't gonna get you any more money,
Right,
right?
and I will,
Good point. So we're
I will
need
touch,
into that.
yeah. I
We're
will
gonna
touch
need
base
that
with
for
her.
the other request of the last resort, medical,
Yep,
non-medical necessary questions.
yep,
You know, we're gonna need that information for that too.
and I will have a meeting with Chelsea again next week.
She had to hop off,
Yep.
but she had put in there in the chat that she will work with you to provide the requested statistics.
Yep. We
That'd
meet
be
every other,
helpful.
yeah, we meet every other week, so. Yeah, so, and again, I know there's annoyances on both ends and we clash on things.
I'm sitting here listening,
I
I
think
don't
we'll-
understand the medical stuff, but it sounds like the billing company is expecting you to dot all your i's and cross your t's and trying to figure out a way to not have to pay something.
I don't know if it's the medical company or the insurance company.
Well, I mean,
Sure, it's-
insurance
And it's the
companies.
insurance. I mean, it's the same thing we deal with at the hospital.
Yeah,
I mean, we have physicians who sit for hours on the phone talking to other physicians to prove that that patient is sick enough to be in the hospital.
Mhm.
And sometimes they say no, and we're like, you can't, I mean, we can't discharge them just because the insurance won't pay for it.
Yeah, and it's on everything,
Yeah.
whether it's a MRI.
God, my
That we're
wife
ordering.
sits on the phone
You
forever
know, stuff like that.
sometimes on
So-
stuff.
Yeah.
She gets so
I mean,
It's
unfortunately,
frustrating.
you're not
That's the
wrong.
world.
I mean, that, yes, that, you said it, that's the world that
Yep.
you all live in.
Yep.
And believe me, and I look at it from a slightly different perspective, because my supplement has gotten so outrageous that I look at Medicare Advantage, but I'm scared to death that with all of the heart problems and stuff that I've got, that they're gonna deny something, you know, just
Yep.
because.
They will.
They will.
Yeah.
They termed that wrong.
Yeah.
Advantage
Yeah.
plan.
Yeah,
Disadvantage.
it's not, yeah,
Yeah.
exactly.
But but eventually, my supplement company will price me out of it. I'm paying $380 a month for a company that pays 20%.
Yeah. So if, for today's purposes, is that something we can commit to looking at the PCS?
I mean, I'm happy to do
And,
whatever.
I mean, we want to see this
Right.
first,
Mhm.
but if there's enough there that would help
Yes,
generate some more
absolutely.
collections on your end. If it's something that we can do some additional information for you in that regard.
Yeah.
And I don't want to throw you under the bus, okay? I really
I
don't.
can handle it.
You're used to it, aren't you?
I know.
But moving forward, and I'm sure that you probably already do this because you are on top of your game. But if we can get, when we do these things, like for example, the fairs, or of course, our fair out here is a little different scenario, but you know, if we're doing a race or something somewhere, you know, I get that. If we can get a third crew
We try,
to commit,
yes.
you know, say, okay, here's our schedule, we're going to do this on August 23rd.
Well, and we talked about some out of the box things last, you know, before the fair to try and make sure that you didn't have to have full crew,
Right.
but also like by partnering with other people, like, is there a potential that only if there's a transport?
Which, yeah. Here it wasn't an issue. The county fair here, Cassie went by herself several times. And then some of the volunteers and, Adam was there, like, so we had it covered and it didn't interfere with our ability to
Right.
cover calls and transfers. But things like Cronky Tonk and some of those other things that we get
Motorcycle.
motocross stuff. Figured you would just know what that is, but anyway, so we get asked to come to those, and again, they need contracts, they need confirmation that we're gonna be there. And if we can't get additional staff, then
By the same token, if we have to leave, they have to shut down anyway.
yes.
And so that's why I was wondering whether or not we could potentially, and I know you work on that, but we say, Abby, are you available on August 23rd to do the race? Yeah, and so then we've got a crew schedule
Mhm.
and a third rig, why it's fixed,
Right,
but I'm just using that as a
Yeah.
hypothetical.
yep.
I think this has been a good start. Good conversation. It's my opinion.
Well, we'll look for the report once you get it.
Yes. Yep.
Yeah.
Oh,
Email it to Stacy and she can forward it on to me. I don't know if you have it. Oh, yeah, Mike.
I do, yes, sir.
I'll see, I can send it to me too. And we'll start looking at those and seeing how to make sure we're getting information for it.
I really do appreciate you all. I seem like it sometimes, but you know, I do. And I trust her explicitly. She's saved my bacon literally more than once. So, especially that one time. And then she said, don't wait so long till the next time.
It's usually a good,
yeah.
it's usually a
that's
good.
That's
piece
good
of
advice.
Well, I will tell you this, just for the record, so everybody would hear that, if I'm out there. There's probably nobody else's hands I'd rather be in than hers. She knows what the hell she's doing. And I'll take it like a sinker. And I chuckled the last time I was out there, my neck hurt so bad. You remember that? The doctor was saying, well, you're not in here just to get drugs. Some people come in here to get drugs. I had never thought about it from that.
Oh, dude, that happens a lot.
A lot.
A lot.
Well, no, I didn't come here to get drugs. Beer maybe, but I didn't come here to get drugs. Never, ever, that would have ever.
Oh, yeah. My
Anything
volume.
else?
Yeah.
For today's purposes?
Are we good, folks?
Thank you. Thank you.
Thank you.
Thank you, guys.
Appreciate it.
What you did. Thank you.
Thank you, everyone.
Thank you, man.
Thanks for your
You're
help.
welcome.
Thanks.
Yep.
Thanks, Stacy.
Yeah.